Good evening, and welcome to our webinar, What Your Doctor May Not Tell You About Autoimmune Disease. I'm David Ward, Chief Science Officer and Director of Functional Healthcare Services for Entavita. We're really excited that you've chosen to take the time to join us this evening so we can share this very important information with you. Now, before we get started, it's important to lay out some ground rules, so to speak. So first, if you have any questions, please type them into the Q&A, and we'll do our best to get to them at the end. Also, as we go along this evening, if you would like to explore working with us, we offer a complimentary 30-minute consultation, and the link to schedule is in the chat. Now, we are recording this presentation and we'll be sending the recording out to all participants. Also, please keep in mind that the information, comments, and opinions expressed in this presentation are those of me as the speaker based on my own clinical experience and interpretation of the literature, and is for educational purposes only, and it's not intended as a substitute for medical care. The lifestyle and nutrition approach presented is not suggested as a cure for any disease. Please talk with your healthcare provider about any information you get from this presentation. Now, I'm going to be reviewing the current standard of care within the conventional medical community for autoimmune disease. And frankly, it may sound like there's a lot of gloom and doom in what I'm going to say, but I would not talk about that without providing solutions. So please hang with me as I go through some of the science of autoimmunity. And later, I'll be discussing how you can take proactive steps to support a healthy immune system. Now, basically, what we're going to cover this evening is why autoimmune disease prevalence is increasing, why the conventional therapeutic approaches have not been completely successful in diverse patient populations, the relationship between genetics, lifestyle, and the environment in autoimmune disease, why SARS-CoV-2 is called the autoimmune virus, the relationship between persistent inflammation and autoimmune disease, the role of environmental toxins such as mold, pollution, pesticides, and plastics in autoimmune disease, and how a functional healthcare approach identifies the underlying or root causes of autoimmune disease and uses immune system leverage points to reduce autoimmune activation and support immune tolerance. Now, whenever I present information that may be a bit controversial because it goes against the established paradigm in conventional healthcare, I like to remind everybody to be open-minded, but not so open-minded that your brains fall out. One of my mentors likes to say, always start with why. So I'd like to share my why for the work that I do. And my why started in 1975 when I was diagnosed with the autoimmune disease lupus. I was 17 at the time, and as a male with lupus in 1975, the prognosis was not particularly good. And the diagnosing doctor told my mother over the phone that she should be happy if I lived to be 30. Very long story short, I struggled with the conventional medical approach for a number of years as I experienced many severe flare-ups and short-lived remissions. And it was only when I discovered the functional healthcare approach that identified the underlying causes for my autoimmunity and used a targeted lifestyle-based approach to remove those triggers that I was able to achieve long-term remission. I like to say that conventional medicine kept me alive, but the functional healthcare approach gave me my life back. As I regained my health, I was asked by one of my doctors to lead support groups for people struggling with autoimmune diseases. Now, creating a sense of purpose by teaching others how to live well, regardless of a diagnosis or medical status, helped me to view my health challenges in a positive way. I became a chiropractor practicing functional healthcare in order to share with as many people as possible the approach that I'm going to be presenting this evening. So let's start off with some definitions. First of all, what is autoimmune disease? Well, it's a broad category of related diseases where a person's immune system attacks the tissues and organs that it's designed to protect. And the immune system produces antibodies, specialized proteins that recognize and destroy invaders in our body. And autoimmune diseases occur when these autoantibodies attack the body's own cells, tissues, and organs. So some more definitions. We're going to be talking about these as we go through. So I want to make sure that everybody is on the same page with what I'll be saying. So antibodies, again, they're also referred to as immunoglobulins. They are protective proteins produced by the immune system in response to the presence of a foreign substance. So this is key, foreign substance. So the antibodies are supposed to react to foreign invaders. A pathogen is an organism causing disease to its host. And whenever I say host, think human, sometimes referred to as an infectious agent or simply a germ. I'll often use the term bug. An antigen is a toxin or other foreign substance that can bind to an antibody or T cell and which induces an immune response, including the production of antibodies. Phagocytosis is a process for ingesting and eliminating particles such as microorganisms like infectious agents, bacteria, viruses, etc., foreign substances, and apoptotic cells. So apoptosis is an anti-inflammatory form of cell death that promotes a resolution of inflammation, as opposed to secondary necrosis, which is a pro-inflammatory form of cell death associated with the spillage of the cell's content, which then damages body tissues. Now, in healthy individuals, billions of cells die every day. And apoptosis is described as an active programmed process of cell death that avoids eliciting inflammation. But if this system fails, and we're going to talk about why this system fails, because it's really important as a driver of inflammation and autoimmunity. If this system fails, cells die through secondary necrosis with uncontrolled release of the cell's contents, creating inflammation. Now, the immune system should be able to recognize an infinite number of foreign antigens without accidentally responding to the host tissues or proteins as harmful antigens. In effect, the host should be immune to itself and only destroy foreign invaders by exhibiting what we call self-tolerance. And there are many ways for the immune system to mistakenly target self-tissue, leading to a loss of self-tolerance. And that loss of self-tolerance is the hallmark of conditions generally classified as autoimmunity. So what causes autoimmunity? Well, scientists don't fully understand what causes the body to produce an autoimmune response to itself. But there are several triggers which are known to play a role in the development of autoimmune disease. Some of those triggers are bacteria, viruses, toxins, hormones, stress, some drugs. All of these can trigger an immune response in a person who has a genetic predisposition to develop an autoimmune disease. We're going to talk about how autoimmunity results from the interaction between genetics, lifestyle, and the environment. Here's just some facts about autoimmunity. There's more than 100 autoimmune diseases, but many, many more that are suspected to be autoimmune diseases. About 50 million Americans have one or more autoimmune diseases, and about 25% of individuals with one autoimmune disease are at risk of developing an additional one. About 75% of those affected are women, and autoimmune diseases are among the top 10 leading causes of death among American women. Autoimmune diseases tend to cluster in families, hence the genetic predisposition, and they're usually chronic and cause major organ damage, tissue and organ damage, and in some cases can be life-threatening. Autoimmune diseases cannot be cured. However, and this is really important, remission is possible. So this was an article that was published on the website of the Global Autoimmune Institute. Now, this website is a phenomenal resource for all things autoimmune. It's got a lot of science and it's got a lot of practical information, and it's cutting edge, up to date with what the latest research is showing. So this was an article from last year that noted that autoimmunity is on the rise. And this recent study, they noted, used the most common biomarker of autoimmunity, anti-nuclear antibodies, or ANA, to show an almost 50% increase in positivity over the course of 25 years. So why is that? Now, many people have some ANA circulating in their bloodstream and may never go on to develop an autoimmune disease. And the immune system has regulatory mechanisms to keep autoantibodies in check. However, these mechanisms may not function correctly for people with autoimmune disease. And while it's true that autoimmune diseases have a genetic component, genetics haven't changed over that 25-year period significantly enough to explain the rise in ANA. However, there have been increases in the amounts and types of environmental exposures that all of us are exposed to. Pollutants, medications, dietary components, viral infections, and stress have all been linked to autoimmunity. Now, how is autoimmunity diagnosed? Well, it requires a multi-step approach because many lab tests on their own are not specific to a particular disease. And it takes specific symptoms combined with specific blood markers to obtain a diagnosis. Now, the lack of definitive tests means diagnosis and management largely relies on individual physician knowledge. And there have been many studies that report inadequate training and knowledge about autoimmune disease on the part of physicians. Autoimmune diseases are commonly misdiagnosed once or more times before definitively being labeled as autoimmune. And that can cause substantial delays in a diagnosis and the lack of treatment that results as a consequence of this delay. And delays in diagnoses are very common, with some studies reporting an average of 6 to 7 years to a diagnosis, and approximately 50% of patients initially being misdiagnosed. This was a landmark article that was published in 2003 that showed that autoantibodies for lupus are present many years before diagnosis. And in fact, the appearance of antibodies follows a predictable course with a progressive accumulation of antibodies before the onset of fully diagnosable disease, while patients are still asymptomatic. Now, this study was followed by additional studies showing antibodies are elevated as long as 15 years before symptoms or diagnosis for other autoimmune diseases, such as rheumatoid arthritis, type 1 diabetes, Hashimoto's thyroiditis, celiac disease, and Crohn's disease. This paper was published in 2007, and they talked about predictive antibodies that appear in the blood years before people show symptoms of disorders. And the author notes that tests that detect these molecules could warn of the need to take preventative action. This paper in the American Journal of Epidemiology was published in 2016, and they noted that while treatment of autoimmune diseases has improved, it's been hampered because the disease often progresses before a clinical diagnosis is possible. And they also note, consistent with those other studies that we just saw, the best biomarker of impending autoimmune disease remains rising autobodies. Now, the early identification of an escalating autoimmune process made possible by the predictive capabilities of these antibodies is especially important when the disease progression can be prevented, even if there is not an official diagnosis of an autoimmune disease, by identifying and avoiding environmental triggers, environmental factors that may trigger or worsen the disease. So this diagram shows the progression of autoimmunity as described in the studies. And you can see that the continuum goes from healthy to autoimmune activation, which is what we call a silent autoimmune stage, where there's elevated antibodies but no tissue loss. Unchecked, that progresses into a pre-symptomatic phase and then to a symptomatic phase. Now, going from autoimmune activation to pre-symptomatic, the antibodies are continuing to ramp up. And so if you did serial testing, repetitive testing over time, you would see that progressive increase in the antibodies. As you get into a symptomatic phase, you have what we call autoimmune reactivity. That's where you have elevated antibodies with symptoms, but no loss of tissue. And most importantly, for this stage, you haven't progressed to the point where you can get a diagnosis. And then when you get to diagnosable disease, that's what we call the autoimmune disease stage, you have elevated antibodies with symptoms and tissue loss sufficient such that you meet the disease criteria. Now, there are two questions that a functional healthcare practitioner who specializes in autoimmune disorders asks. The first is, where is the autoimmunity? Is it tissue specific? Or does the individual have systemic autoimmunity, meaning it's attacking multiple tissue sites? The second question is, what stage of autoimmunity is the individual in? Are they in a silent stage where they have antibodies but no symptoms? Or are they in autoimmune reactivity, where they have the symptoms, but it's not full-blown diagnosable disease? Or do they actually have tissue destruction, where symptoms are present, antibodies are elevated beyond the threshold, so it's possible to diagnose their condition, as we see here? And we can answer those questions with testing that looks at multiple tissues that commonly are targeted by autoantibodies. So we can see predictive antibodies before full-blown disease occurs. Now, for many individuals, a laboratory finding is not sufficient for an autoimmune diagnosis, and you end up in this phase here, where you can be in this stage, and oftentimes you'll go to your doctor and you'll hear, well, it might be autoimmune, but we don't know for sure. You don't meet the criteria, your antibodies aren't high enough. Come back and see me in a year and we'll check it again. Now, diagnosis is important from a conventional medical perspective in order to assign an ICD-10 code, largely for insurance purposes, and therefore allowing for prescribing the corresponding medication. But from a functional perspective, we also look at you as being on the autoinflammatory autoimmune spectrum. And in all autoimmune diseases, the common thread is an immune response that attacks healthy tissues and cells and organs. So the underlying condition is really autoimmunity. And the way it's expressed in terms of tissues targeted and specific symptoms becomes the diagnosed disease. In a functional healthcare approach, we identify and resolve the underlying causes that result in the autoinflammatory and autoimmune conditions rather than treating the named disease. Now, this was a commentary in a publication called Science Daily on an article that was published in the journal Sociology and Science and Medicine. And they noted that when the disease is hard to name and doesn't have visible symptoms, it can be hard for other people to understand that you're sick, especially when people don't know much about the disease and it's hard to explain. Patients with autoimmune diseases often have an illness experience with symptom ambiguities and shifting diagnoses. And research has found that diagnostic difficulties and negative medical interactions can generate persisting psychological damage and insecurity, particularly among those who were met with disbelief or were given psychosomatic or a mental health misdiagnosis. And this is particularly true for people with autoimmune diseases, where the condition is chronic, but achieving a diagnosis may take time. The diagnosis may change, symptoms may not be overtly apparent, and in many cases, a cause and a cure are unknown. So many of us who have been in this autoimmune disease maze have experienced this, where you go to the doctor, you know you're sick, but the doctor says your lab tests are normal. And so you don't have an autoimmune disease. Now, let's talk a little bit about autoimmune disease treatment. Now, this is not my deepest area of expertise. When I work with somebody, what I do is I look at the specific medications that are being taken, and I associate that with what treatments we're going to recommend to make sure that the treatments are consistent with the medications. Now, I am not anti-drug. I am not somebody who says you should not take medication for autoimmune disease. As I said earlier, conventional medicine kept me alive. I would literally not be here having this conversation with you today if it wasn't for conventional medicine. And I'm very grateful for that. But there are shortcomings with the conventional pharmacological approach that we're going to talk about now. So first of all, there is no autoimmunologist medical specialty. Autoimmune disease symptoms are treated typically with an organ specialty approach. And medical specialists typically familiar with autoimmunity and the specific diseases they treat include dermatologists, endocrinologists, gastroenterologists, immunologists, internists, neurologists. So where your symptoms are, that's the specialist that you will see. But there's no or very little connecting the dots of all of those symptoms to recognize, again, the underlying condition is autoimmunity. Doctors commonly prescribe immunosuppressants to reduce immune system activity and disease symptoms. And some treatments act on the entire immune system, while others are more targeted therapies. This paper was published in 2020, and it noted that in general, the current drugs used for autoimmunity are broadly acting, not disease specific, and associated with side effects, such as infections and malignant disease, cancer, or increased risk for cancer. And it's clear that the majority of patients are not responding optimally, if at all, to these therapies. Now, if you're one of those patients that's doing great with drug therapy, I am thrilled for you that you have found that. I struggled personally with multiple drugs that didn't work. Some of them made me worse in a lot of different ways. Ultimately, finding the right drugs that stopped my disease process while I addressed the underlying causes. But some people just don't respond optimally, if at all. And these therapeutic approaches have not been completely successful in diverse patient population. So what tends to happen is if you have a diagnosis, let's say it's rheumatoid arthritis, the assumption is that everybody with rheumatoid arthritis will respond the same to a particular drug that's developed based on a certain pathway of the disease process for RA. but everybody has different genetics. Everybody has different triggers. Everybody has different lifestyle. Everybody has different environment. So you could put 10 people in a room with rheumatoid arthritis, and their presentations will be very different. So the efficacy comes at the expense of side effects, particularly, again, increased risk of infection. And with this paper, this was just published last year, what this notes is that emerging therapies aim to induce tolerance without compromising immune function. Now, let's talk a little bit about inflammation because it is a driving force of autoimmune disease. So we know that an abnormal inflammatory response is involved in the majority of acute and chronic conditions, and there is strong evidence linking chronic inflammation to the development of autoimmune disease. And while many treatments, as we said, rely on decreasing inflammation, they don't work for everybody. They can have serious side effects. And so the authors of that article posited the question, could a more precise understanding of the inflammatory mechanisms behind the broad range of autoimmune presentations pave the way for better therapies? So this is a paper from the Journal of Immunology Research from 2019, and they note that inflammation is a normal physiological process. It defends us against pathogen infections and tissue damage, and normally it resolves quickly. However, in many chronic conditions, the inflammatory response continues and leads to tissue and organ damage. And the authors state that knowledge of the mechanism of inflammation regulation will lead to significant clinical benefits for the treatment of autoimmune disease. And ongoing research is showing that many chronic autoimmune challenges may actually be defined as autoinflammatory, and they're mediated by cells within the innate immune system. Now, it's important to understand that the immune system is not one thing that goes up and down in total. So when somebody says your immune system is overactive, that's not entirely accurate. What part of the immune system? Because it's not one thing that goes up and down together. When somebody says you shouldn't take immune boosting supplements because your immune system is overactive and you'll make it worse, well, what part of the immune system are those supplements boosting, and which part of the immune system is affected? And the problem with autoimmunity arises when an individual becomes stuck in an overexpression of a particular kind of an immune response. So what we want to do is we want to be able to downregulate or dampen the autoimmune process while at the same time upregulating or supporting immune responses against things like toxins, viruses, or bacteria. And you can't do that if you view the immune system as being one thing. Now, this is a schematic of the immune system, and this looks complicated because it is, and that's why I put this up there. Now, I'm not going to go through this, but when we talk about the immune system being overactive, well, is it this part? Is it this part? Is it this part? It doesn't all get overactivated together. And in fact, there's usually some part that's overactive and some part that's underactive. So the immune system is made up of, or referred to typically as, a combination of the innate and adaptive immune systems. So the innate immune system is considered to be the first line of defense and is considered to be non-specific. It reacts the same way every single time. So this is the part of your immune system that gets involved at the onset of an infection, bacterial infection, viral infection, a parasite, or if there's a toxin in your tissue. And it includes mechanical barriers such as your skin and mucous membranes, chemical barriers such as stomach acid, and the inflammatory process itself. The adaptive immune system primarily involves T and B cells, or T and B lymphocytes. And the adaptive immune system is able to recognize invading organisms with a high degree of specificity. And it also has memory, which allows a second invasion of the same antigen to stimulate a quicker response. And that memory is achieved by expansion of T and B cells after they encounter an antigen. And we're going to talk more about that, because that's how we get elevation in things like antibodies. So this is just a diagram of the immune system. Here's the innate immune system, the rapid response system, and you could see that it involves all of these cells. These are your white blood cells, macrophages, neutrophils, eosinophils, basophils. This is your adaptive immune system with your T and B cells. And you can see there's some overlap here with what are called gamma delta T cells and natural killer T cells. And they have characteristics of both innate and adaptive immune system. This is a LabCorp blood test. This is a complete blood count with differential. And so this is where you would see the innate immune cells, which are also called phagocytic cells. And you could see that I've got those highlighted with the arrow. Those are your neutrophils, monocytes, eosinophils, and basophils. And then your adaptive immune system, which is your lymphocytes, which are your total B cells, total T cells. And with LabCorp, they also include natural killer cells. So the way the immune system basically works is that when a pathogen enters your body, let's say it's a virus that gets into your lung tissue, and immediately you have a response within hours of the innate immune system in the form of all of these cells: neutrophils, eosinophils, basophils, mast cells, and again, those natural killer cells. And they attack and basically neutralize that pathogen. And then they go through a process which is called antigen presentation, using antigen presenting cells in the lymph nodes to B cells and T cells. And the B cells make antibodies to what was presented, and the T cells differentiate into subclasses based on the type of antigen presented. So I'm going to get into a little bit more detail about that. Now, we know that that a mandatory definition for autoimmunity is a loss of self-tolerance, which is typically caused by antibodies in the adaptive immune system. But the innate immune system really does take a leading role in the initiation and maintenance of autoimmunity. Now, this is a diagram that shows that innate immune process in multiple phases. So innate immune cells reside in tissue. So just to orient you, this is the blood up here. This is the inner lining of a blood vessel, which is called the endothelium. And then this is the tissue below it. So this would be the lung tissue on the other side of the blood vessels. And residing in the tissue are immune cells, like macrophages, that sense damaged tissues or pathogens. So in this diagram, they're talking about damage, but it could be a pathogen. In our example, we're going to use virus. What those macrophages do is they produce cytokines, inflammatory chemicals. You may have heard the word cytokines. It was popularized during COVID when we talked about the cytokine storm. So macrophages produce cytokines that induce neutrophils from the bloodstream to come into the tissue. And those neutrophils ingest or phagocytize those pathogens. And then they send out chemical signals. And as they're doing that, they undergo programmed cell death called apoptosis. So the neutrophil basically ingests the pathogen, the virus. It kills it with toxic particles that are inside of the neutrophil, and then it calls for reinforcements in the form of monocytes that turn into macrophages. And they send out signals that inhibit other neutrophils from coming into the cell and encourage the monocytes from coming into the cell. Now, the macrophages then come into the cell and they engulf the neutrophils. You can see that what that looks like right here. And then once that's engulfed, they give off anti-inflammatory chemicals that you could see here and anti-inflammatory chemicals that you can see here. And this macrophage neutrophil pathogen complex then exits the tissue into the lymph system and goes to the lymph nodes and is then presented to the B and T cells. So that's immunology 101 in about 2 minutes. Now, where can this process go wrong? Well, there could be too many neutrophils coming into the tissue. The neutrophils, when they come into the tissues, they're on a clock. They're not going to be there forever, and they're on a 6 to 10 hour clock. And if they are not engulfed by macrophages within that time, they die by necrosis, which we defined before. And that's a very inflammatory form of cell death because they spill their contents, which are toxic, into the tissue, and that creates tissue damage. So now you have more tissue damage that the macrophages in the tissue are going to see, and they're going to call for even more neutrophils to come in. So too many neutrophils coming in, not enough macrophages to neutralize the neutrophils. So there can be tissue damage. And then the other thing that can happen is there's inadequate, what we call resolution chemistry. Now, when the macrophage ingests the neutrophil, it gives off signals that produce these products right here, called lipoxins, resolvins, and muresins. And they basically tell the neutrophils to stop coming in. So there's two different mechanisms that tell the neutrophils to stop coming in. So stopping the neutrophils from coming in must be a pretty important process in the resolution of inflammation for there to be redundant systems for that to happen. Now, the other thing that happens is this complex of macrophage, neutrophil, and pathogen gives off these chemicals, which are profoundly anti-inflammatory. They turn off the inflammation process. Now, one of these chemicals called PGE2 actually gets inhibited from chronic use of nonsteroidal anti-inflammatories like Advil. So while in the short term, using NSAIDs might not be a bad idea for a given individual, long term, in the literature, they're referred to as resolution toxic. They prevent the resolution of inflammation. So that's another place where this can go wrong, is that you have insufficient resolution chemistry. Now, chronic or sustained inflammation is an indication that there's either a failure of that resolution or a persistence of triggers. So let's talk first about failure of resolution. And this paper published in 2016 in Frontiers in Immunology noted that, again, inflammation is a reaction of the host to infections or tissue damage, and inadequate or insufficient resolution leads to chronic inflammation, excessive tissue damage, and dysregulation of tissue healing. And it has been implicated in multiple disease states, including the development of autoimmunity. Now, that excessive tissue damage and dysregulation of tissue healing can result in presentation of self tissue to reactive T and B cells, as we noted. So again, the process of resolution involves clearance of the macrophages in combination with the neutrophils and the pathogen. But if there has been a lot of tissue damage that is part of that neutrophil macrophage complex, that will actually go to the lymph nodes and be presented to your B and T cells. And your B cells will look at that and say, you know, I think it looks like you, but it also looks like a virus. So I'm not sure. So just to be safe, I'm going to make antibodies to that self tissue. Now, the back end of that process is that once those B and T cells identify the pathogen and they produce the antibodies, they go into a massive clonal expansion. You get about 1 million B and T cells from that. And then those B and T cells and antibodies that are specific to what was presented go back to the tissue where the problem was. So if you've got a virus in your thyroid gland, which does happen, and it damages your tissue, and a combination of virus and thyroid tissue is presented in the draining lymph nodes to B cells that make antibodies to that thyroid tissue as well as the virus, then those antibodies go back to your thyroid tissue and they attack the thyroid tissue with those antibodies. We know that improper phagocytosis, which is the programmed cell death of apoptotic cells, contributes to the progression and of a number of chronic inflammatory disease. Now, in a healthy individual, billions of cells die every day by apoptosis. That is the healthy, normal cell death, right? You're constantly turning over cells. And so removal of those dead cells must be efficient to prevent that secondary necrosis that damages the tissue because of the release of the contents in the cell. So the program has to be efficient. Now, let's talk a little bit about persistence of triggers. This paper was published 2020 in Journal in the Frontiers of Immunology, and they noted that the most challenging aspect of autoimmunity is to identify the early events that trigger the immune dysregulation and autoimmunity. And you really have to go back upstream from the symptoms and the onset of diagnosis to look at the sequence of events that occurred. Did you get a virus as a kid? Did you have exposure to chemicals in a job? There's this virus that's out there. You all probably have heard of it. It's called SARS-CoV-2, and all of us got exposed to it. What we're going to see in a little bit is that that is now being called the autoimmune virus. So strong evidence exists linking environmental agents with the development of various autoimmune diseases. And environmental factors account for 70%. Genetics only accounts for about 30%. So we know that there's a genetic component to autoimmunity, but the interaction of all of these different environmental factors with the genetics is what results in the autoimmune disease. And the exposome, an individual's lifetime exposure to external and internal factors, is a key component of the development of autoimmune disease. So there's external factors like stress, your lifestyle, air pollution, both indoor and outdoor. And then there's internal environment like things, gut bacteria and inflammation. And it's your lifetime exposure to these triggers that results in autoimmunity. This was a paper that was presented at the 13th Annual International Congress on Autoimmunity in 2022. And the author noted that the solution to autoimmune diseases is to detect and remove the triggers and then repair the damage to the body and restore health. These were a couple of articles that were published on the website of the Global Autoimmune Institute. You can find them there. molecular and immunological evidence for SARS-CoV-2 being the immune virus, and autoantibodies linked to immune diseases are associated with COVID-19. And what the authors noted was the increased inflammatory reaction by the virus results in tissue damage, causes systemic autoimmune related manifestations in patients with COVID. And there's several different mechanisms for that. I'm not going to go into those because it's really detailed and complex immunology. But suffice to say, there is a lot in the research now showing that the virus that causes COVID, SARS-CoV-2, can be an initiator of new autoimmunity, and it can be an exacerbator of existing autoimmunity. What about long COVID? Well, there's also questions being raised about, is long COVID a new autoimmune disease? And the authors of this article, again on the Global Autoimmune Institute, noted that one of the most troubling mysteries about long COVID is the diverse things that occur in people with persistent COVID symptoms. And one theory is that long COVID can be an autoimmune disease. And studies have noted that there are shared symptoms between long COVID and suspected autoimmune diseases like chronic fatigue syndrome, which is now referred to as myalgic encephalitis / chronic fatigue syndrome, or ME/CFS. We'll call it chronic fatigue for our purposes, and also fibromyalgia. So chronic fatigue syndrome and fibromyalgia are now being viewed as likely autoimmune diseases. And there are a lot of similarities between those conditions and long COVID, such as persistent fatigue, widespread muscle pain, memory difficulties, and mood disorders. Now, we're planning a webinar coming up in the next couple of months about the effects of COVID neurologically, on the immune system, and it's both acute COVID illness and a strong emphasis on long COVID. So if you're interested in attending that, please let us know in the chat, and be sure to include your email address so we can get you on our list for that. Now, if you've been recommended or you've read to avoid gluten, it's very likely that you were influenced by the work of Dr. Alessio Fasano out of Boston, Mass General, and Harvard. He is the researcher who literally put gluten on the map as a trigger for autoimmunity. He discovered how gluten triggers chronic inflammatory disease. And what he said was, apart from genetic makeup and exposure to triggers, which we've already seen, there are 3 additional elements causing chronic inflammatory diseases: an inappropriate increase in intestinal permeability or leaky gut, a hyperbelligerent immune system, and the composition of the gut bacteria. So I want to focus for a minute on this concept of a hyperbelligerent immune system. Now, immune tolerance refers to an unresponsiveness of the immune system towards something that is normally capable of stimulating an immune response. So basically what that means is the immune system has to be able to look at a lot of different things. 1 million cells die every second in the human body. And there's also cell death in response to infection. So the immune system has to look at all of those cells and all of those pathogens and decide which ones to attack and which ones not to. And so they're looking for a needle in a haystack that is very, very difficult to get perfect every single time. But the immune system, for most people, really does an effective job at basically weeding out self-tissue versus pathogens. So self-tolerance is essential for normal immune balance, and failure or breakdown of that tolerance is what results in autoimmunity. And here's a diagram that shows how that occurs. So all of the different triggers that we talked about, stress response, infections, food reactions, hormone changes, toxins, pollutants, all of them cause the immune system to become dysregulated. And you lose self-tissue. Basically, everything that's up here creates an immune response and inflammation. And in people that are predisposed genetically, that can cause that immune dysregulation and the loss of self-tolerance, which then results in production of self-tissue autoantibodies. And again, you start off in a silent autoimmune stage, then you could progress to autoimmune reactivity and ultimately possibly to autoimmune disease. Now, I showed this diagram earlier, and I want to focus just on the T cells because T cells are areas that we can exert significant leverage in terms of getting the immune response to go the way that we want it to. So this is a diagram that shows that T cells receive antigen presentation. So again, going back to what we talked about before, this might be an antigen presenting cell involving a macrophage with a neutrophil and some virus particle in it. And that gets to the lymph nodes and presents this particle to what we call an undifferentiated or naive T cells. And that antigen presentation involves 3 different signals that ultimately decide which subset of T cells this undifferentiated one becomes. Now, there's actually about 7 or even 9 now of these of these T cells. We're going to focus just on these 4. And you could see that these 3 signals will determine this. Now, a couple of things I want to focus on. You have Th1 cells, and Th1 cells are involved in clearance of intracellular pathogens, within the cell pathogens. Think viruses, okay? Th1 is your primary adaptive immune response to viruses. Th2 is extracellular pathogens. So that's pathogens typically in mucous membranes or what we call hollow spaces, sinuses, respiratory tract, digestive tract, intestines, vaginal tract, urinary tract, and bladder. So that's responsible for clearing out pathogens there. Th17 is associated with the clearance of extracellular pathogens as well, but it's also associated with tissue inflammation and autoimmunity. And then there's the regulatory T cells or Tregs that are responsible for tolerance or immune suppression. Now, these 3 signals decide which of these cells, which of these types this undifferentiated cell becomes. So signal 1 is says basically, there's something here. There's an antigen that I am going to hand to you. Signal 2 says, I want you to become interested in this. And signal 3 is the actual cell polarizing signal that tells the naive T cell what kind of an antigen it is in order for it to differentiate. So you've got to have all 3 of these signals in place. There's actually ways that we can leverage the fact that you need these 3 signals. So if you have a propensity to go down this route instead of this route, we can use these signals to our advantage to balance these out. And I'm going to get more in detail on that in just a moment. Now, the pro-inflammatory activity of the Th17 cells can be beneficial to the host, as I said, during infection, especially GI infections, for example, Candida or Klebsiella. But uncontrolled or inappropriate Th17 has been linked to a number of autoimmune diseases. And they've been associated with the tissue damage. Whoops, I didn't mean to do that. They've been associated with the tissue damage because they produce pro-inflammatory cytokines. So the tissue damage in autoimmune disease is actually caused by the Th17 cells. It's not caused by antibodies. And in fact, accumulating evidence suggests that the Th17 Treg balance underlies the pathogenic mechanisms that drive autoimmune disease. And here's just a sampling of some of the autoimmune diseases that Treg and Th17 imbalance can be seen in. Lupus, autoimmune thyroiditis, both Hashimoto's and Graves', MS, RA, Sjogren's, systemic sclerosis, irritable bowel, psoriasis, both types of autoimmune diabetes, both type 1 and what's sometimes referred to as type 1.5 or latent autoimmune diabetes in adults. In addition, this Treg Th17 imbalance plays a role in many metabolic disorders, including cardiovascular disease, type 2 diabetes, and osteoporosis. Yes, osteoporosis is an inflammatory disorder. It's driven by Th17. It's not primarily driven by a loss of calcium in the bones. Now, this paper published in the journal Molecule noted that this is an attractive target for drug therapies, and substantial progress in understanding the balance between Treg and Th17 creates a high therapeutic potential for drug therapy targeting those populations. However, they note that autoimmunity is complex. And that explains some of the observations that certain strategies are effective in some autoimmune disease for targeting these cells, while exhibiting no effect in others. And in fact, they note that there are still multiple challenges to identify, develop, and implement the ideal Th17 Treg interventions with respect to autoimmunity. And what they mean by ideal, the drug that will resolve Th17 Treg imbalances across the board in autoimmune diseases. Well, we know that autoimmune diseases are diverse. The presentations are diverse. And so it's hard to imagine that a one-size-fits-all drug approach, which hasn't worked so far, is all of a sudden going to work. So how do we approach autoimmune and autoinflammatory disorders from a functional healthcare perspective? Now, I showed this earlier, and I want to reemphasize it here because I'm going to be speaking about nutraceuticals. The lifestyle and nutrition approach presented is not suggested as a cure for any disease, and please talk with your healthcare provider about any information you get from this presentation. Now, there is significant research that supports the efficacy of nutraceuticals in chronic inflammatory disorders. And as part of an overall strategy involving diet, nutrition, and lifestyle, they can provide significant benefit on an individual basis. But it's important to recognize that individuals with a sensitized immune system need to exercise caution with supplementation. Some nutraceuticals can have interactions with medications such that they can affect drug metabolism, effectively making them more or less potent. And nutraceuticals, and for that matter, pharmaceuticals as well, always contain fillers and other ingredients that are included, for example, to support the manufacturing process or make the product more palatable. And those fillers can cause reactions, especially in people with mast cell activation. And in those folks, they can react to just about everything, even bottled water, which I've actually seen occur. So it's best to be evaluated and followed by a knowledgeable provider for your particular need for supplementation and your response to it. So one thing we can do is support the resolution of inflammation by using nutritional therapy. And this process of resolution is coordinated, as we noted before, by specialized pro-resolving mediators that are derived from essential fatty acids, omega-3 fats, the stuff that's in fish oil, and healthy fatty fish. Functional lipid mediator profiling, in other words, testing for your level of these essential fatty acids, is a new approach for defining the optimal dosing for essential fatty acids, omega-3s or fish oil supplementation in order to design effective nutritional therapy. So we could support resolution of inflammation by identifying whether or not there are sufficient building blocks of inflammation resolution chemicals through advanced diagnostic testing. And this provides the necessary information for determining the optimal dosing strategy. Now, it's not a good idea to just say, well, take fish oil, because if you take in high dose DHA, which is one of the 3 fats in fish oil, and you have a lot of what's called oxidative stress, and that means you're producing a lot of free radicals, if you're familiar with that term. That's like not having the flue open in your fireplace when you light a fire and all the toxins back up in your body. If you have a lot of that oxidative stress and you supply DHA, it can actually create inflammatory products that create brain inflammation. So you have to supplement judiciously with essential fatty acids. We can also use a process that we call nutritional immunomodulation, where specific nutrients and an anti-inflammatory tissue environment promotes tolerance and supports immune health by a number of mechanisms, including balancing that Treg Th17 that we saw earlier. So this is a similar diagram to what we saw before, and we know that those specialized pro-resolving mediators derived from fish oil control chronic inflammation, but they can also modulate T cell responses. So again, here we have that naive T cell that has the potential to differentiate into all of these different cells. And what you see here in the light green are the particular products that SPMs or pro-resolving mediators provide that inhibit Th17, that inhibit Th1, that inhibit Th2, and promote regulatory T cells. So we can actually promote this balance here with optimal levels of essential fatty acids. The other great thing about that is that once Tregs are supplied with enough SPMs, they start to make them on their own. So this becomes a self-supporting loop. We know that environmental factors such as the gut bacteria and diet alter cytokine regulations with potent effects on Th17 differentiation. An inflammatory environment in the gut promotes Th17 and downregulates or dampens Treg. So it promotes that imbalance that causes the tissue destruction in autoimmunity. This paper notes that recent resident microbes provide enormous advantages to the host. And one of these mechanisms is through controlling Tregs and Th17 cells. Now, when they talk about resident microbes, they're not talking just about the gut bacteria. In particular, they're talking about, in this paper, the bacteria in your mouth. Now, there is certain oral bacteria that are known to cause body-wide inflammation, and they're actually known to be part of the causative mechanism in chronic inflammatory disorders like autoimmunity and Alzheimer's disease. And if you have bleeding gums, you have a breach in the barrier, effectively a leaky gut in your mouth. And that allows these inflammatory bacteria easy access to your bloodstream. Your immune system looks at them and says, that's not supposed to be here, and it mounts an inflammatory response. Plant-based chemicals or phytochemicals derived from certain natural products are potent regulators of this process, and they exert protective benefits against gut inflammation. Now, here's another one of those diagrams that shows the differentiation. And basically, the way this is showing it is that naive T cell, in the presence of these chemicals, will differentiate into this cell, and then this cell will give off these chemicals, and these chemicals allow this cell to do whatever it's supposed to do. In the case of Th1, attacking intracellular pathogens, as we said, viruses. Now, we know that the Th17 activation is an important item in the process of autoimmune disease. So here we see again that antigen presenting cell coming to a naive T cell that can differentiate into Th17. But the Th1 pathway inhibits this. So if we can activate or support Th1, it actually dampens the Th17 response. This chemical right here called interferon gamma, it actually prevents Th17 from making these inflammatory chemicals. And the two chemicals that you see here, the IL-17 family, those are the actual chemicals that Th17 produces that damage tissue. And the way that they do that is Th17 cells and the IL-17 chemicals promote influx of neutrophils into the tissue. And we said that too much neutrophil influx causes tissue damage. So this is how Th17 causes that tissue damage. But we can interfere or intervene in that process by activating Th1. Now, what you see on the screen here is a very common pattern of T cell imbalance or polarization in autoimmune disease, where you have an overexpression or a dominance of Th2, a relative decrease or dampening of Th1 as a result, which results in an inhibition of the Th1 blocking Th17 that allows the Th17 to get ramped up. Now, typical signs that an individual is Th2 dominant is being prone to asthma, allergy, whether it's seasonal allergies, food allergies, allergic rhinitis, eczema, sinusitis, upper respiratory tract infections, urinary tract infections. Those are all associated with a Th2 dominance. And factors that increase that Th2 in dominance include inflammation, especially in hollow spaces, like the intestines, lungs, sinuses, vaginal tract, bladder, and urinary tract. Also, stress chemistry results in a Th2 dominance. Mold and candida. Mold is a huge driver of autoimmunity. It is largely overlooked, and it is really, really significant because it creates this imbalance and drives this Th17 response. Toxins like pesticides and plastics can contribute to this imbalance. Head injury, because of the chemicals that are released as a result, can lead to this dominance. Sleep disruption can do it. Now, Th2 dominance also drives mast cells, which are part of the innate immune system, to make histamine. And so that's part of the reason that Th2 gets involved in allergy and asthma, because of those mast cells. Now, in the brain, mast cells activate immune cells called microglia. and cause them to produce inflammatory cytokines, leading to inflammation and symptoms like brain fog, fatigue, malaise, and decreased ability to be physically active. And mast cell activation is an overlooked yet potentially treatable contributor to symptoms of chronic fatigue and fibromyalgia, and is known to play a role in long COVID. And it's theorized that COVID infection can lead to an exaggeration of existing mast cell activation, or could activate normal mast cells, creating a new mast cell activation. So it's important that we address this imbalance. And we do that by supporting a Th1 response, which we said blocks Th17, and that Th1 response also diminishes the Th17 response. Now, it's important to understand that this imbalance that I'm showing here is common, but it's not universal. And sometimes you'll actually see individuals that have a Th1 dominance pattern. So that's somebody that you don't want to create more activation here. And that's typically somebody with maybe a new autoimmune disease as a result of a new infection, or a patient with an arthritic condition like RA. And in those cases, you can't use Th1 to downregulate Th17. You have to address Th17 directly. So you have to be evaluated for this pattern in order to understand what the person needs in terms of support. Now, for supporting Th1, we can use nutraceuticals like Bicalin or Bicalin, which is also known as Chinese skullcap. We can use berberine, sulforaphane, glutathione. We can modulate Th2 with things like perilla and astragalus. And then we can use direct inhibition of Th17 and upregulation of regulatory T cells with things like curcumin and resveratrol and omega-3s, vitamin A, vitamin D, and EGCG, which is a major component of green tea. Now, I wanted to throw this in there now that we're talking about this imbalance, because COVID creates that same sort of imbalance that I just showed you, with an upregulation of Th2 and a downregulation of Th1. And that Th2, Th1 interplay affects patient outcomes. And studies show an association with worse outcomes and higher Th17 in all COVID patients. And in fact, patients that die from COVID tend to have a Th17, Th1 imbalance. Remember, we said Th1 is the T cell specialized to attack viruses. So what SARS-CoV-2 does is it downregulates the process designed to kill it as part of what's called a pathogen evasion strategy. From an immunological perspective, this virus is really pretty smart. It's incredible. What it does to avoid detection and get a foothold before your immune system can catch up. And clinical trials of Th2 or Th17 inhibition have identified potentially protective mechanisms against viral effects by enhancing Th1 immunity. And again, we have to do that on an individualized basis. Now, how do we know if you have that pattern that I showed you or some other pattern of T cell imbalance? Well, we can look to your history, your signs, your symptoms, and most importantly, from a functional healthcare perspective, your story. And when we look at that and we combine that with specific testing, we can identify indications of the T cell imbalance. In addition, there are also tests that we can do that will directly measure the balance of all of those individual T cells and the B cells. So this diagram basically shows what happens in autoimmune activation. We know that inflammation is a driver of autoimmunity, and autoimmunity also can cause inflammation. So what causes inflammation? Well, all of these things that we have listed here can cause inflammation. Imbalance in blood sugar, food reaction, defects in detoxification, toxins, hormone imbalances, oxygen deficits like anemias, insomnia, overtraining can drive autoimmunity. I can't tell you how many times I've seen somebody who gets an autoimmune flare-up from overtraining. In addition, we know stress chemistry activates inflammation, and inflammation activates stress chemistry. And stress chemistry lowers Th1 status, which leads you susceptible to infection, which can cause autoimmunity or inflammation. And inflammation can cause imbalance in gut bacteria, leading into an increase in Th17 and autoimmunity. So you can see the complexity. And what we have to do is we have to identify all of these contributors on an individual basis. And then we create a functional healthcare approach that involves education management, where we identify and understand that the normal course of autoimmunity, because autoimmune diseases are not curable, is a pattern of relapse and remission. And the goal is for those relapses to be less frequent, less severe, and of less duration. We also need to identify your personal triggers within all of these categories of dietary issues, antigens, chemicals, immune barriers, supporting immune tolerance, all within lifestyle management. This is a study that was published in the Journal of Family Practice last year that showed that lifestyle is one of the few modifiable risk factors impacting the development of autoimmune disease. And they said that there's emerging evidence that lifestyle medicine, a functional healthcare approach, is a potent tool to treat autoimmune disease. So why isn't your doctor talking about this lifestyle approach? This graph shows that before the current healthcare system that we have in place now, humans used to die at an earlier age. And it was usually due to infections and trauma. Now, with the current standard healthcare that we have, we tend to see a longer lifespan with gradual decline in health and vitality, including a decline in immune health, which is known as immunosenescence. And in fact, a study was just published a few days ago that showed that the US continues to far outspend other developed nations on healthcare while seeing worse health outcomes, such as being more likely to suffer from multiple chronic illnesses and having a shorter life expectancy. And these results provide more evidence that our current healthcare model fails to confront both the causes of and solutions for complex chronic diseases like autoimmunity. But research supports a third option. Through a personalized lifestyle-based approach, we may have the possibility of a different trajectory, one that combines a more consistent quality of life and the overall length of life to support health and vitality over the health span. Now, this evening, we've shown that autoimmune activation can lead to chronic inflammation, and symptoms can start years before a diagnosis. And we've also shown that there are multiple triggers for autoimmunity related to the interaction of genetics, lifestyle, and the environment. And while some in the conventional medical community acknowledge the importance of lifestyle and environment as contributing factors, most physicians are simply not trained to assess for the underlying causes of chronic inflammation and autoimmunity, or to recommend individualized lifestyle-based strategies for prevention or reversal. And in fact, studies have noted that it takes up to 17 years for new basic science research to make its way into clinical practice. So it's possible that your doctor may not even be aware of the information that you've seen this evening. In addition, the conventional medical approach may not have a therapeutic option until a diagnosis of autoimmune disease is made. Now, we've shown that we can identify and resolve the underlying causes of the autoimmune disease through a personalized lifestyle-based treatment approach. And we've also shown that there are multiple inflammation leverage points where we can intervene and influence the autoimmune process. We encourage you to take action now, to take proactive steps to support a healthier immune system, because your mind and body today are the results of your habits yesterday, and your mind and body tomorrow are the results of your habits today. I want to thank you all again for spending your time with us this evening. We went a little bit long, but we're still going to have some time for questions if there are some. I especially want to thank those attending from the East Coast and Puerto Rico who stayed up past their bedtime to hang with us this evening. I know this was a lot of information, and I hope that what you've seen this evening has provided you with a clearer picture about how the immune system becomes dysfunctional, leading to chronic inflammatory and autoimmune diseases. I also hope that what has been presented will inspire you to take action to support your immune health. Now, at Entavita, we have different programs available to assist you doing just that, including individualized one-on-one care and also group programs that focus on education and lifestyle. So if you would like to explore those options further, please click on the link in the chat to schedule a discovery consultation. So now I want to take a look. We did get a few questions. Let's see. Is there a link to autoimmune disease and allergies, asthma, eczema? Yes, Michelle, as we showed, that Th2 dominant type of presentation or person that has that Th2 dominance tends to have that type of susceptibility to allergies, asthma, and eczema. And also, Michelle, yes, we're going to be sending out the recording from this video this evening, so you will get that. Okay, let's see, were there any other questions? It doesn't look like there were any other questions. So again, I want to thank you all for sticking with us this evening, and I hope you have a great rest of your evening.